Hi everyone, this is Taylor with the Daily Geddon, and today we're going to talk about healthcare. More specifically, we're going to talk about the Medicare For All Act of 2019. The bill number is S1129, and it was a bill that was introduced by Bernie Sanders into the Senate. Now, I know that this bill is a hot button issue, and a lot of people have conflicting ideas of exactly what Medicare For All is. So today we're going to clear some of that up, and we're going to get into what it actually says and how it applies to Americans. And hopefully we'll learn something. We should start with the state of American healthcare today. And in a census from the Census Bureau on census.gov of 2018, 91.5% of Americans were insured in 2018. So that leaves 8% of the population that is uninsured. Of the 91.5%, 67.3% of the population was insured by some type of private program, and 34.4% of the population was insured by some public program. We'll call it 67% and 33% just to give the census a break. Of the 67% that were insured by a private program, 55.1% were covered through their employer, and that is the largest contributor to American health insurance is the employer. Undoubtedly, Americans are faced with a heavy burden when it comes to healthcare costs. A study done by the International Federation of Healthcare Plans shows the median cost of standard procedures in other countries as a percentage of the median cost of the same procedure in the United States. From the study, typically the United States pays quite a bit more than other countries. Diving into a specific one of these procedures, hip replacements in particular, the average American pays about $10,000 more than the second highest ranked country in the study. The data that backs this study up comes from MarketScan databases, and these databases are created by IBM, and they're for this exact purpose. It's this huge collective of healthcare information just to generate reports like this. Other information was provided by these Kaiser Health plans, and it was audited and verified by Deloitte Consulting LLP. With that, we'll get into what Medicare for All actually is. And Title I sets up the universal healthcare program, and it states that there's comprehensive coverage against all health costs and health services. Not only that, but it sets up universal entitlement, meaning that all United States citizens are covered under this bill. It also sets up the freedom of choice, meaning that there are no more in-network or out-of-network doctors. A doctor is a doctor. It also sets up an enrollment device, an automatic enrollment device, as well as gives an effective date. The effective date for this bill is 4 years after the enactment of this bill, and it lawfully prohibits any private insurers or employers from duplicating any services that are provided under this bill. Title II of this bill actually tells us what's going to be covered in these benefits, and what's covered is hospital services, ambulatory patient services, primary and preventative services, prescription drugs, mental health services, laboratory services, comprehensive reproductive and maternity and newborn care, pediatrics, oral health and audiology, as well as vision services, short-term rehabilitation, emergency services, any transportation that's needed in order to perform healthcare, as well as support for those that are in long-term living communities or nursing homes. Title II also gives the government a way to react to advancements in medicine. Because medicine is going to continue to evolve in the future, we're going to need to make sure that all Americans have the same base coverage across the entire United States. It also says that there is absolutely no more cost sharing, no more deductibles, and no more co-payments. Except with certain drugs and certain preventative medications, there's a $200 maximum should the Secretary of Health and Human Services see that as a need. The first part of Title III is not that interesting, and it just lines out the requirements of being considered a doctor that can receive funding from this bill. And it basically says that if you can lawfully practice medicine in a certain specified field, then you are allowed to be a doctor and covered by this bill. The interesting part comes in when they start talking about private contracts, and the use of private contracts is an agreement between a patient and a doctor that goes above and beyond what is covered by Medicare for All. And that's perfectly legal under this law, but you will have to pay those expenses out of your pocket. So if it's something that's not covered in this act, you will have to pay extra money on top of what we're going to talk about later, the monthly premiums that you will pay under this act. Title IV is for administration, and it lines out exactly what the Secretary of Health and Human Services is going to have to do. And interestingly, they have to provide procedures and planning for pretty much everything in this bill. They have to provide procedures and planning for enrollment, how we determine who's eligible, how we determine if doctors meet requirements so that they can be funded by this bill. They have to determine all the levels of funding. The most interesting thing, however, from Title IV is that we're going to have one centralized source of information. The Secretary of Health and Human Services is going to have to set up ways of reporting on everything in this bill, and we're going to have statistics on just about everything in healthcare, and it's all going to be in one spot for once. You're not going to have to go to multiple insurers, multiple agencies, different accounting companies to pull all this information, like that report at the beginning of this video said. And I think that that is one of the best things that we can have, is that we can finally look back at history and see how things are working or if they're not working. If anything comes out of this bill, we need something similar to that. Title V of this bill is about quality assurance, and it requires that the Center of Clinical Standards and Quality go back through the Public Health Service Act and make sure that all the practices and criteria for the healthcare that we're going to receive are up to standards and that they meet the quality that we're looking for from this bill. Also, it requires that the center go back and report on demographic data of patients in order to make sure that the quality of care is spread evenly across the United States. Title VI of the bill is probably the most important part of the bill because it sets up the budget for universal health care. And with that, it brings us to today's pivot. Part A of Title VI of the bill sets up the skeleton for the healthcare budget, and it requires that the Secretary of Health and Human Services allocate money to things like quality assessment, continuing education for healthcare professionals, administrative costs, and innovation costs. Part B of the bill is probably the most interesting part because it deals with cost containment. And by cost containment, I mean that the Secretary of Health and Human Services has to come up with a standard schedule of values for basic physician care, and for all physician care actually. And by doing that, by standardizing costs, we can actually reduce them because there's such a wide fluctuation in how much things cost in the healthcare system. It also sets up a way for the government to negotiate prescription drug prices. And that's something that happens in most universal healthcare systems, and it reduces the cost of prescription drugs. Title VII in this bill sets up the Universal Medicare Trust Fund. And the Universal Medicare Trust Fund is all of the money that would have been appropriated to Medicare, Medicaid, or any other state-run healthcare plan. It also states that all of the money that's not appropriated from the last fiscal year will be diverted into the Universal Medicare Trust Fund. So that means that we're trying to create some kind of rainy day fund with any money that's left over in the budget. Titles 8 and 9 are changes to the Social Security Act of 1974 so that those laws now conform with this new bill once it gets passed. In particularly, it gets rid of duplicative employee health care as well as all Medicare and Medicaid services because those are now covered within this act. Title 10 in the last section we're going to talk about today details out the transition period between the current healthcare system and Medicare For All. It starts by decreasing the eligible age for Medicare by 10 years for every year after this bill has been enacted. It'll go from 65 to 55 in the first year, 55 to 45, 45 to 35, and finally on the fourth year everyone will be covered. It also details out how premiums are calculated. The Secretary for Health and Human Services will generate a report every September that estimates costs for healthcare in the next year. That cost is then distributed amongst everyone that's covered and eligible for this plan. There is assistance for these premiums available in this bill. That assistance is calculated on a household income basis relative to the poverty line. During the transition period, there is no out-of-pocket expense for healthcare greater than $1,500. There's also no expense for out-of-pocket drug costs greater than $305. The bill also details out that dental and vision care will be covered for 80% of the cost. I am personally a proponent of centralized healthcare. I think that standardizing the system is a good thing. And I definitely think that the US is moving more and more towards universal healthcare. Now, whether it'll take the form of Medicare for All or not, I don't know, but I think that we are moving that way. And from this interview with David Culler, who's a healthcare economist from Harvard, David Cutler says that in this case of Duke University Hospital, there are 900 hospital beds, so there's available beds for 900 patients, but there are 1,300 billing clerks. That's 1,300 people trying to figure out how to pay insurance providers. That is a massive amount of overhead that's pushed onto the customer. And I know that hospitals today are run like a business, and any cost that they can, they will push off onto the patient because they know that insurance companies will pay it. I mean, there has to be some kind of reason for the disparity between these huge amounts that Americans are paying for the same kind of healthcare that we're seeing in other countries. Anyways, thanks for watching the video. Make sure you follow me on Twitter, and as always, have a good one.